in those rosters in the main EMS, we
Kind
can
of
do something.
resembled her.
And great for myself. So if you want a copy of the roster, email me and I'll email you a copy of the roster. And like I'm taking now all my rosters because I check off the National Registry. Not only is it a main approved class, but I taught it. That's kind of like set you up for like they call it the audit. So I'm taking all these things down. I'm loading them into my National Registry and filling them full of data and all that stuff, and kind of keeping that from getting audited. You know, they'll give you your recertification every 2 years, and then they can also audit you when it's a pain. You got to get all your paperwork together, mail it to them, and approve that. Everything you said you did, you did. You know, so I'm just gonna. So maybe wants a copy of the roster now. I want to email it to you. I'll send it tomorrow. I appreciate Sue for contacting me, longtime coworker, pal, and all that, and did a program up in Windsor a few weeks ago on pediatric emergencies. And it was kind of help them keep licenses going, and so I had some fun up there. It was a small group, it was good, and CEHs have been tough to get, so everybody is kind of moving around a lot of places, going to classes. If anybody's interested, next week from Tuesday in Bremen, at Bremen's request, I'm doing airway, breathing, ventilation skills with mannequins and ventilating them, BLS skills and suctioning and stuff like that. Like I said, an hour and a half, but it's a BLS skill if you need it. You know, come on down, and I got one big mannequin that's in tortured shape, which is perfect for the class, and some other stuff. And also, you know, airway mannequins is tortured, and it'll be good. And then the 26th, Thursday night, a week later in South Thomaston, I got the respiratory failure class that I use the lungs with, the animal lungs. I got a batch. I got a freezer full of animal lungs right now.
What time are you doing that one, Kevin?
6 p.m. And I did it in Bremen a couple weeks ago, and so it's another. That's a ABC. That class gets ABC hour and a half hour trauma, because with the lungs we do some trauma stuff with the lungs, and it's kind of a fun class to do. So all that. So anyways, pediatric emergencies, kind of like a pediatric emergency. A guy, 10, 15, 20 years ago, whatever his name is, and you know him, Chief. A guy named Gordon Graham. I went to his lectures years ago. He was one of these. I think he was a law enforcement person with a PhD in organizational, all kinds of stuff like that. But he came up with this little matrix of like calls that we all go on in this world, whether it be police, fire, rescue, ambulance, all that stuff. And he kind of talked about like the calls that are high frequency, low risk, no big deal stuff we do every day. You know, calls that are low frequency, low risk, da da da. Then you know, come to pediatrics and that whole little matrix of things. Pediatric calls can be low frequency. We don't get them that often, and they can be high risk. It's kind of important to focus on those, because it's one of the things you just don't do that often. And when you look at that kind of a mentality, what basically is when you show up on scene, you kind of need to be a little bit of a Dr. Phil, because you got to sit back and kind of keep the parents happy, got to keep them under control, because now you get two patients, parents as well as the patient trying to deal with. If you show up on scene and freak out and freeze, frozen. Okay, if you freeze on scene, parents read that, and all of a sudden, holy smokes, things are going to be out of control. They're going to have no faith in you. They call 911. You're going to save the day. You show up and like, oh my God, call ALS, call like that right there. That's bad. So when you show up on scene, you kind of need a Dr. Phil to kind of keep the parents under control, keep the parents happy. If that can be done, sometimes it can't. You need a Dr. House who can be the sit back and be the inquisitive, thinking, holy cow, regimented thing. And why is McDonald's in there?
Make them happy.
No, you don't have any meals. No. The answer really is that on pediatric calls, you always have to program yourself to be consistent. That's what the only thing McDonald's has going for it, is consistent. Everywhere you go in the country, it's the same menu, same thing, you know. So consistency is the word. Okay, that's what McDonald's is doing there. You know, you have to be consistent. If you let the emotions, the yelling, and all kind of stuff right there get you kind of wound up, you can get off your game a little bit and forget things. So consistent practice is important. So you can walk in and keep focused, keep the parents, listen to them, but not tune them out. Take care of the kid who's sick, not doing well in front of you. Be consistent on how you do things, and then the calls may have things may go in the right direction. You know, one of the consistent things that I always talk about, like in pals or peers, is that pretty much any approach to a pediatric patient, the two things you should have in your hand would probably be, number one would be an oximeter, because most of the calls that go on are going to be respiratory. And if they're not, still having a pulse rate and oxygenation knowledge is still important to know the overall status of the kid. The browser tape is another important thing. And like a lot of folks who say like, well, I'm not a medic, I don't use this and that, da 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 da. All the medicines on the back of the browser tape, paramedics don't use anyways. We use them, but under different dosages for main protocol. But knowing that the kid happens to be a purple or a green on the browser tape is very, very helpful. It may not be so much to an EMT base, because I'm just a basic, whatever, no matter. It's important, because once the kid's like the kid's a violet or whatever is on the pediatric tape, all that kind of helps the whole sequence go in motion. So most of the stuff we do is by weight-based scenario. So my consistent way of attaching going to a pediatric call, hopefully a pediatric kid is on a vehicle you're working on, and again it's the pulse oximeter with a child probe and a Prowso tape and stethoscope probably, and at that point there, pen and paper, you pretty much got a good half the batch of stuff you're going to need right away when you get there. That's consistent. So anyways, important as well, because some of the stuff in the drug box is very, very important, very, very powerful, and we're not really on our toes, going back to the Gordon Graham idea of the high risk, low frequency medication administrations in a critical situation. That's important. It's almost, nowadays, a new, anybody been in paramedic school this last year or so, the new regime now is to have the cross-check medication system. That is, I draw up the medication, I look at it, I verify it, da 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 da, then I say, okay, please verify the medication, make sure I did it right, type of thing. And have someone else verify it. That's now the new National Registry standard. A lot of stuff going on about that, and like basically because, like in adult doses, we pretty much know we got cardiac arrest. What medication will be given to somebody with thumping on their chest? Epi, right? I mean, and how much epi are we going to give them?
A lot.
The whole container, right? The whole thing of the syringe. I mean, so really, there's really not a whole lot of risk there, mistakes that can be made doing that. But yet, in the pediatric situation, that's a whole different ball of wax. So I don't want to talk too much about cardiac arrest tonight, but I do have my three-way stopcock, which is kind of the best way of using medications. I know what the level of the crowd group was and all that there. So anyways, medications in the box really are kind of powerful. A group of Winthrop had a get-together, Winthrop ambulance crew had a get-together last Saturday. One of their active members was doing a NASCAR medic thing down south somewhere in Atlanta. Anybody hear the story?
Oh, yeah.
Yeah, and he was no diabetic, went to the field hospital at this NASCAR event, and he was low, and they gave him something to sweeten him up a little bit, put an ambulance, take him to the hospital, and they're gonna give him a bag of D5 or something down the way to the hospital, except they gave him a bag of pre-mixed 2 grams of lidocaine.
Oh.
And the poor guy's on the phone with his wife when he died, okay? And she doesn't have a lawyer, she's got a law firm, I'm
Yeah.
told, that's like unbelievable. So I mean, really, like, the thing is, well, they had a normal saline shorts, they put this bag in a certain place and all that kind of stuff. So I mean, really, and listen, we talked about that yesterday at work, like, yeah, so that's why the drug box is there. Stuff we always keep in mind. So anyways, a lot of difference in kids versus adults. And like when you talk like little babies, you got a little mouth with a whole lot of tongue. And the proper way to plug an airway into a kid really is going to be a tongue depressor and let that insert in. And the method we use, put the airway in backwards, turn it around, put the base of the tongue, that kind of stuff there. Kind of is very different. You need to use a tongue depressor to do it. Because you get so much space in there, it's all filled up by a tongue. There's also differences in the anatomical airways and everything. So, a few things like that. Everybody's pretty much heard that before. Other differences, though, is that kids' metabolic rates are higher. And like, for instance, you're looking at a kid who's been sick for several days, not feeling good, sepsis, maybe stuff like that going on. Little babies fill diapers up by the hour. And like in your questioning, in your consistent questioning, you should always be kind of calls, is be like, have you changed any diapers the last couple hours? It's always an important question to ask. Kids, newborns, the ones you hold like this big here, they produce 4 cc's of urine per kilogram per hour. Okay, that's a high metabolic rate. Children like a 3-year-old will be half of that. And adults, notwithstanding coffee, beer, things like that, we're only half a cc per kilogram per hour of urine output. So kids are really heavy duty filling diapers up. And really when your body starts going into shock from dehydration, sepsis, things like that, your body, the hormones, the ADH hormones kick in and start shutting down the kidney's urine output to preserve volume, which is why somebody can have also highly concentrated urine. So if the kid's diapers kind of like all of a sudden not filling up like they used to be, not so much that's going to be a matter to us. But the idea of being the Dr. House I had up there on the screen earlier is that when you go into a house sometimes, to a residence, we're taking care of a kid, and you know, things are kind of like, okay, this is happening, that's happening, that's happening, is you're going to be a hunter-gatherer of information. And the information may not be relevant to you or like makes a big difference, but like try to find everything out you can, write it all down, and head to the hospital with information that this happened, that's going on, mom said this, mom said that, and all kinds of stuff. And it may not be relevant to us, but it just may help the continuity of care and things going right in the hospital later on when those statements are looked at. You know, so the hunter-gatherer of information is a very critical part of good pediatric care. The kid's not breathing, turning blue, different story. I'm no hunter-gatherer there. What are you gonna do? Yeah, it ain't gonna work, you know. Okay, so okay. Anyways, so differences in kids, metabolic rates are higher. One of the examples there has been used for years is like, you know, in a warm summer afternoon, evening, and 21-year-old, because it's legal, had a few drinks and jumps off the dock and dives underwater, and a minute or so later the friends, buddies are like, where is he, where is he? They dive down, they find him, drag him up on the dock, thump on his chest a little bit, he barfs like, oh, wow, man, what happened, you know? That person can handle the lack of oxygen for a few minutes. They're not any more stupid than they were in the first place. But like a 1.5-year-old following mommy around with a mop, falls head first into a bucket of water, is in there for like 30 seconds. That's a serious hit for that baby, okay? And babies can't survive that, okay? And serious results happen, okay? From hypoxia, breathing down, heart stops, all that kind of stuff. So they really have more, you know, there's things that are very important. They will have more energy consumption. A highly stressed baby, say for instance sepsis, pneumonia, a sick baby, may not have a history of diabetes. I wouldn't go jumping for the glucometer first, but in your care plan over the next minutes and whatever, you know, at some point, glucometer is not getting a lot of glucose is not a bad thing to do. The kids have more oxygen demand, and of course, once respiratory failure occurs, they start getting very bradycardic. So if they start getting quiet, slowing down, things like that, and that's a bad sign. Illness or injury does accelerate stress overall, and like I talked about the kid that falls in a bucket of water, they have less compensatory reserve to lack of oxygen in the bloodstream. So that's kind of the key differences the kids have. And kids don't have the ability, adults do, probably like maybe from 10, 12 age up, have the ability. But for folks in the 10, 12 and up above, 12 of us sitting here, if we need to increase cardiac output, we've got a stronger heart muscle, we can make more of a squeeze. We can also tighten up the systemic vascular resistance in the body so that each squeeze gets stronger, more blood pressure, but yet little kiddies don't have that reserve yet. Okay, the only way they can pick up a greater demand for blood flow is to pick up the rate. Okay. You talk about a 30 pulse. When you get a 30 pulse of somebody, the blood pressure may still ring in at like 140/90, but you can barely feel it. You ever had that happen? That's because the natural catecholamine, epinephrine type stuff has been released in the body, which has tightened up the periphery, getting blood back to the core, because the body now is like fight or flight crisis mode. Where kids don't have that systemic vascular resistance ability yet, nor they have the ability of the heart to squeeze and pump a lot harder. Okay, so things there, like they got really, can narrow a little cliff before things go wrong. Anyways, they can maintain the blood pressure longer than adults, and then they can, at that point here, those textbooks and lectures say they kind of fall off the cliff of blood pressure. I'm not really sure about the whole mechanism of that, maybe other people do, but anyways, per weight, they may have more blood volume per weight, but overall less volume compared to an adult. And with infants, whether breastfed or not, they have a very limited ability to fight off bad infections, things like that. So little kiddos who are 3-4 months old can catch something from somebody in the community, the family, daycare, sorry, whatever. Okay? They can pick up something, get infected, and be very sick. And probably the worst things you can look at as a sick kid is both a respiratory problem with pneumonia, they can't breathe, things ain't going good, with pneumonia left not noticed for a while, they become septic, now blood pressure starts dropping, and so that's one of the worst things to do. And of course, most of those kids, we show up here at the hospital, where do they go? Back to the door, Angel 1, and head to main med, you know what I mean? So yeah, we all know that, you know. And yeah, anyways, in infants too, the preemies do lack the subcutaneous brown fat, and babies, kitties, preemies, all that kind of stuff can get cold really quick and have very bad outcomes from that. Cold kiddos and newborns, I got a newborn thing at the end here, because I told you it's a little smorgasbord of all the stuff I kind of do and everything. And you know, keeping babies warm is important. One talk I went to one time said that to keep an ambulance warm for a patient, you may be stripping clothes off, including kiddos. You can have the temperature in the back of the truck at 86 degrees. And you'll be on your t-shirts, you'll be sweating as well, but at that point, so what? It's about the patient, you know what I mean, and all that, so that's kind of an important number to look at. Hot packs are a questionable thing. As a young lad, 3-year-old, was plucked out of the river. He was cold hypothermic, did CPR, he lived, but hot packs were used and he received burns from the hot packs. So that's something to always keep in mind, that adding warmth is one thing, maintaining warmth is another thing, and hot packs are something to be used with great caution. They do make these large hot packs sheet like this right here to put on top of, underneath a towel or a blanket, to put a premium on top of that for transport. And still, that's it's kind of risky business. One of the best things I ever heard described from somebody in a newborn situation at home was to take a bunch of towels, throw them in the dryer, warm them up. That became a great receiving blanket. That made a lot of sense. You know, no risk of burning someone that way. So some of the differences on kiddos, and our vital signs have all kinds of differences, but I can't remember them, and maybe you can't either. But and of course, the other thing is we got a nice chart in the main EMS protocol book, but I need my reading glasses and even see those. So if I bring my iPad around with me, maybe I can dig them up there, but I don't know, just, you know, numbers and such. So, anyways, length-based tapes are important. Everybody should have one. State passed a whole bunch of them out a long time ago, and you know, it's the thing here, and kind of like it tells you the weight and everything. And there are some easy methods for calculating epinephrine for cardiac arrest using a 1 to 10,000 mixture. That's your weight-based resuscitation tape. If the tape is 3 or 4 years old and it's out of the date and something like that, it doesn't matter, because the weight's still going to be the same. The kids are purple, the kids are purple. The rest of the stuff in here don't really matter a whole lot to us. They're all differences. We don't do RSI stuff and all that. The Versed dose on here is for like RSI. We don't do that. So really all those dosages are not really worth it. Nick at Northeast took the time and trouble, guy we worked with, a great guy, and he took the time and trouble and matched up all the main EMS dosages for every color code, and then he took the Browser tapes and he made those labels and stuck them in there. That's kind of cool, he did that. A lot of work though. And another thing too out here, anybody heard of this before? No? Okay. I went to class a couple weeks ago on it, pretty cool. And it's done by Dr. Eugene Antevi, who, oddly enough, is also the medical director for Coral Springs Fire Department Rescue, which is where Parkland High School is. And there's a whole video program. He does a lot of stuff on YouTube. You can find his Antevi moments. He talks about asthma and a lot of other things there, and he's got a whole bunch of ideas. And he has his Antevi method so that a 1-year-old on the thumb, probably weighs 10 kilograms. Okay, first finger, a 3-year-old weighs 15 kilograms. 5-year-old, 20 kilograms. It's kind of a ballpark system. I texted my daughter Megan today to see what Wilson and Walter weighed, but she said they won't stand still long enough to be on a scale. The boys are 2 and 4, my grandsons. So I'm going to try to prove this out and see if it does work or not. I just talked to Chrissy at the store a few minutes ago, and Gail Lord's daughter, and her little 6-month-old is now, he's now 10 pounds. Got a little baby, so I mean, so maybe his formula's close, maybe not, but anyways, it's the Antevi method. And the idea of 10, 15, 20, 25, and 30 are possible weights in kilograms. And the thing that I heard years ago was questioned, and I didn't know the answer, but in his program, he talks about the Browser tapes are good tool to use. And if the kid is a little on the chubby side or quite chubby, the weight is not accurate according to the length. So I was kind of wondering about that. And then Antebi said that in his program is that pretty much medications are going to be water soluble going into the bloodstream, not going into adipose fat. So the fact that the kid may be a little butterball doesn't really matter all that much. My son Kevin was on soybean when he was first born, and his pictures of him he's huge, and then now he's thin, and I don't know where he got that from. He didn't get it from me. But anyways, so supplies are important to have, and 2 OB kits is pretty much something we should have on our truck, because 1 just isn't enough. And Browntree has 00 size airways. They're a little tiny, this big, and they're important for preemies. And they're worth having. They're like $3. Okay, you go digging through Browntree catalog somewhere, you'll find it. Every PD kit should have one. We all get the pink one, which is the standard newborn. But the thing is, the one that's going to need help with is going to be actually the preemie, not so much the newborn. Newborn really needs help, but the preemie is going to need help. And blow-by device is important. When you see in the books and EMS literature about, like cupping your hand with a hose, all that kind of stuff, but just, you aim a hose in the kid's face, the kid's going to be upset, move away and everything. And the thing I've used for years, and Mark's helped me out a few times at getting some of them, are these Venturi adapters. Those firefighters are foam reductors, certainly. They never break down, they don't need batteries, they always work. But the adductor, the Venturi thing here, you stick your oxygen line into here, put it on 8 to 10 liters a minute, whatever, and these 2 ports here are pulling room air with it. But now what you got coming at the kid is a wall of oxygen. Not a straight stream that's going to sit back and upset the kid and move his face away. And what's great about these right here is you can actually put them for transport to main med, stick it under the strap in the car seat, aim it up the kid's face, and the kid's got a wall of oxygen coming at him. You the ones you grabbed me once with the other brand Venturi masks have a little color code. They look like Fisher Price color code ones there. A couple of them have got real big holes in them. I take those and use those, and those are great devices. So blow-by is a critical thing. Of course, the pulse ox is important. BVM and manometers are kind of good for newborns. You can buy those extra. I mean, there's like $5-10 extra and all that stuff right there. And medication administration, I'm a big believer in the 3-way stopcock, and not having medication errors, and a browser tape. Those are some supplies you need to have. And protocols look at, review, it would be like the pink one. It used to be called the ATLE, LT, it used to be the apparent life-threatening event. And now, to be consistent with the rest of New England's protocols, the brief, resolved, unexplained event where the kid would maybe looked funny, wasn't breathing for a second, choked, coughed, sputtered. Mommy called 911 when you get there, the kid's fine, happy, looking at you, and like, what's it all about? And there's a whole thing in your main protocol about that. However, you should encourage mom to take the kid to the hospital with you, keep an eye on the kid, because something happened there. And a lot of times those mommies, though, will pick up the baby when something like that happens. They'll shake little Johnny, whatever, he comes to her, right? And they'll take the kid to the doctor's office, because the pediatrician's the expert, not the emergency room. Okay? And once I have an emergency room, what's the doctor do? Call 911, we come over and pick up the kid. That's happened a lot, So anyways, we look at the seizure protocol. We can give IV or IM medication for Versed. We also can do intranasal dosing. I got the dose at the end of it there. If these things apply to you, you should look them up ahead of time, because going back to what I said earlier about the low frequency, high risk episodes, these are certain things you should know where to find them accurately, quickly, and not make a mistake. If not, have somebody verify when you do it. When it comes to wheezing and pink 11, we got the dexamethasone, Decadron stuff to use, and also nothing else is working. Magnesium, 50 milligrams per kilogram over 10 minutes. But again, over 10 minutes, we don't just dump it in like a bolus, like wham. Maybe a slow drip going in. And wheezing, asthmatic type things really should be a pharmacological solution, not a intubation and that kind of stuff right there as well. And in Tevi, he actually has in one of his YouTube videos on how you can kill a kid who's having an asthma attack by intubating the kid. it goes back to the fact that you're putting a positive pressure into the chest, expanding the lungs, reducing blood pressure back to the heart, and blood flow back to the heart, to the large thoracic pressure, will kill them. It's kind of like, wow, stuff like, you know, again, it goes back to the thing I said before, I'm going to say it again. The high-risk, low-frequency situations, you know, we want to do good. And of course, the other thing too about hypoglycemia is using the D10. What's our dose for D10? What's our starting for the bag of D10?
For Pete,
Yeah,
that's why I have protocol book.
it's easy, 50 milliliters. Up to 22 pounds, 50 mLs. If you go to 44 pounds, then 100 mLs. It's really an easy one, you know, it's kind of an easy one to do, you know. So anyway, it's kind of like, so it's kind of the, I'm a little ahead here, okay. So anyways, those are some of the stuff and protocols to look at. And like they gave me the card, one of the Life Flight folk gave me a card one time, that they stick in a little neat thing, and they got the little pouch and all stuff right there, and the card was, on the way to a hospital, when they're flying, they find out the kid's weight, and they do all their drug calculations on the card ahead of time, based on the weight. So when they get there, you can pull out the card and say, we're gonna do this. That's kind of cool. That again goes back to addressing the high risk, low frequency situation. Medication administration is important, you know. Okay, so anyways, respiratory distress is a big part of the calls, and it can be a whole different batch of things, which croup-and epiglottitis, and viral stuff, and RSV, asthma is more going to be, you know, you start getting to 5-6-year-olds and all that. Kids can have the abscesses, which are infections, which we really can't see so much. It goes into like tonsillitis, stuff like that as well, and of course foreign bodies and all that kind of good stuff can go on. All that. So anyway, so about respiratory distress, the biggest part of the calls we probably go on. The pediatric assessment triangle has been used for years as the kind of the standard for looking a kid over when you walk in the door. And the triangle is, of course, appearance, what the kid looks like. Work of breathing is a critical thing. And those two things aren't going well. Circulation is the next thing you look on your checklist of like, I've got a very, very sick kid versus okay, we can sit around for a few minutes, get some oxygen on the kiddo, ask a few questions, find a few things out, you know. So anyways, is a kid awake, alert, hopefully? Do they look at you, you know, a tot pretty much, you know, is going to cling to mommy, cling to a caregiver, and kind of like not be happy with you in the room because you're a stranger. You know? And the kid makes eye contact, knows you're there and all kind of stuff. At least for the first couple of moments, you know, the kid's kind of like doing okay. There's still a reason they called us. We're here for a reason. We got things to do maybe. At least right now, I don't have a scoop run because I got, you know, a kid's gonna die in front of me. But if the kid's drowsy, not attentive, all kind of stuff, then you can have a lot of issues going on. So work of breathing is an important thing. Mostly increased respiratory effort can be a pulmonary problem, which could be the croup, bronchiolitis, the RSV, all that stuff there. But also, when you look at work of breathing, someone who's septic, has a bad fever, very hot, they're going to breathe fast and burn off the heat, blow it out the heat. That's one of the things the body can do. You can have someone with a rapid respiratory rate, burning up, crystal clear lung sounds, and a 99 to 100% sat. And the reason they're breathing fast is because they're trying to get off the heat. Metabolic acidosis can do it when someone is, you say like a 10-year-old who's newly undiagnosed, not recognized, diabetic ketoacidosis. At that point, they're pretty much unresponsive. They too will have crystal clear lungs, a high sat. They'll be breathing, they'll be moving volumes of air, kind of almost a reddish pink complexion. And they're breathing so fast, increased respiratory effort, is not because they're lacking oxygen, they can't breathe, they're trying to blow off acid. That's an important thing to realize too. You know? Dehydration can do it because once the body starts getting shut down from lack of volume, circulating blood volume, again the tissues also start to become acidotic, and that's another reason you can have some rapid respiratory action, as well as toxic ingestion. That's a biggie. A bottle of aspirin puts you in an acidotic situation. But again, when it comes to kids and swallowing things, you know, they take mommy's methadone tablet, you know, that kind of stuff right there. Well, you know, I wasn't on the call, but that stuff happens. I wasn't on call where the kiddo took Grandview sleep and beta blockers, pain medications, and down around Freeport, in the back of the truck, I couldn't wake the kid up. On the monitor, everything was looking good, but I'm not looking too happy. The mom's reading it, and she really read it well. When I picked up the phone and called Remus and said, I need to have some docs ready because I've got a kid that I can't wake up and arouse. You know what I mean? So the mom at that point really kind of read that. I was kind of like, but I kept, oh, look at the screen, Mom, everything's good, you know. And then we back in the main med and hit the bumper there, the kid wakes up. There's a whole bunch of doctors out in the white coats. So, anyways, things like, but I mean, probably the kid was like sedated, taking Grandview's pills, things like that, you know. And people also take, you know, beta blocker overdoses are very big for, as well as adults, some accidentally, some intentionally, and kids can do it as well. And of course, work and breathing can be heart failure. Some things about heart failure can happen. It's very, very, very tragic. Unfortunate is newborns released from the hospital, everything went well, and mom and daddy brought home a little bundle of joy and everything, and then 3 or 4 days later, the baby's irritable, pale, not doing well, breathing rapidly, and nothing's making sense, and then you find out the poor kid had hypoplastic left heart syndrome, which is a very rare, but it does happen in Maine a couple times a year, I've been told, of the heart not forming properly. And at that point there, the circulation doesn't occur, and pretty much within days, the poor baby succumbs to it. And the best mom and dad can do is hopefully the organs go to some other baby that needs it. So it's those kind of those calls you look at and like, nothing's making sense. So you know what I'm gonna do? A, get out the BVM, put some oxygen to it, ventilate this kid, and B, feed the hospital and keep them warm. There's no sense sitting on the scene trying to figure things out. You know, so heart failure can be a big issue out there. And we look at heart failure too in a newborn. Actually, that's a newborn section. We'll learn about that. Anyways, work of breathing. So anyways, a lot of different things you can look at for work of breathing. Pick up the rate is important. That's a good clue. You know, nasal pharynx is the body's trying to open up the airways to make things happen easier. The kid's trying to find a good position. The best position for a kiddo, if they're alert and kind of knows you're there, is going to be actually sitting upright in mommy's lap. And the human body is much more efficient in an upright position for the lungs to work than laying down. I think someone who's got a bad rib cage fracture, bad trauma of the chest, and having trouble breathing, moving air, pretty much you lay them down flat. What are they going to do? Rip off the straps and sit upright because they feel like they're suffocating. That's a common thing that happens a lot. Retractions are working so hard, they're actually now sucking in all the soft tissue, lack of muscles, trying to expand the rib cage, everything they can, every muscle they have, and the stuff's being pulled in. And the grunting is also another one. Grunting is an important thing. That's when they've got more of a lung tissue disease, like pneumonia. When you look at the PEERS or the PALS programs, the Heart Association gives you 4 different types of breathing problems. One of them is disordered control of breathing. What it really means is perhaps they had a seizure, not breathing properly, got a bit of head injury, fell, something went wrong, and their breathing rate is irregular. Okay. Another one they have, of course, is going to be upper respiratory airway constriction, like stridor, epiglottitis, things like that. Lower airway obstruction, asthma, bronchiolitis, things like that. Another one they have is lung tissue disease. And really, it's a Heart Association's terminology, but what it comes down to basically is going to be pneumonia, infection in the lungs. Okay, so that's where you get that. And grunting is like when you have somebody like a case of pneumonia, the alveoli sacs are kind of filling up with a little bit of pus and crud and things like that. When a kid grunts, the grunt's going to be on the way out, and they're actually going to try to close up the glottic opening and try to maintain a volume. It's actually self-PEEP. Now we use a PEEP device on our CPAP. If you know that, but that's what's on our CPAP, it's a PEEP. And the PEEP keeps the airways open a little bit. Hopefully you're still moving a volume so you don't have air trapping. But grunting is it's pretty close to it. I got a video that might kick in if it works on here. That's trying to breathe against a closed glottic opening to maintain alveolar space. And late signs are going to be seesaw breathing. That's not good. And then a real bad sign is going to be head bobbing. You get a kiddo who's not looking good, unresponsive, head bobbing. At that point, they're trying to get every muscle they can to try to breathe, expand that space, everything. A kid who's head bobbing is pretty much proverbially on death's doorstep. And what's your best thing you can do for that kid?
Run up his airway.
Actually, get the BVM out, breathe with them, okay? Because at this point now, they're in respiratory failure. They're not in distress, okay? Distress is one thing. Adults, we can verbalize the stress. A little short of breath. Around the building a couple times. Once I'm short of breath. Okay, that's distress, right? Okay, big flight of stairs. I'm stressed. Kids can't tell you that. So really, you got to use outward clues of where is the stress, and where point does the stress now become respiratory failure. If they're in respiratory failure, at that point there, aggressive action is yes, diesel. Okay, but also get out the BVM. Stick a non-rebreather on somebody and say, oh, I give him 15 liters of non-rebreather or 12, okay? That really just not really quite enough. You need to breathe for them, Get out the BVM, and it's the best thing you can do for a kiddo. Adults as well, All right, so anyways, the respiratory failure continuum is respiratory distress on the yellow side there, the early outward easy signs. And probably some of those signs may be one of those kind of deals where mom or the caregiver or whatever, they're kind of like, yeah, I'll give him some cough medicine, might be okay, I'll give him some Tylenol, children's Tylenol, bring the fever down, no, I'll make an appointment, he can't see the doctor till tomorrow, okay, we'll go to the doctor's office in the morning, kind of stuff like that. Maybe when they're kind of in that yellow zone, they probably might be kind of okay, but stridor's not a good thing. When they start moving into the middle there, now we're getting into respiratory failure, where things are going bad. Color's not good, retractions, grunting, working hard to suck air in. When they work very hard to suck air in, there's obstructions in there, the chest will actually collapse inward. Okay, and the ribs are really almost the word I'm using for, kind of like similar to half-cooked thick macaroni noodles. Is kind of like they won't kind of fall over, flop over, but they're not not really strong yet. Made older adult bones, So when you get head bobbing and wheezing, mottled look, grunting and stuff like that, you've got a kid now who's failing, and pretty much get out the BVM and put the oxygen with as well and start ventilating with them, with their effort. And if you look at the main EMS protocol, it'll say there, in the basic level, it'll say, assist ventilations with 100% O2 PPV, positive pressure ventilation. So getting out the BVM is a key thing, They need a lot more than just non-rebreather mask. And of course, once they start slowing down and bad seesaw respiration, the color is purple, things like that, then you get some big problems. And kids who are very sick from respiratory failure, whether it be pneumonia, a bad respiratory situation going on, a bad infection, stuff like that, they really got a double whammy going on. They probably may have trouble maintaining circulatory volume if they're septic from pneumonia. Okay, that's one whole problem that's massive. On top of that, they can't breathe right. That's massive. So really a kid who's in that kind of fits that pneumonia type of thing right there, that's a kid who's critically ill. And like if I was in St. George, I worked on there one day a week occasionally. Yeah, I work on it tomorrow. I mean, if I had a kid who was that sick, a baby that bad, it'd be like, why go to Penn Bay? The hell with it. I'll just bag the kid here on Fort Clyde, and I'll call Lifeline. That's what the kid needs. Penn Bay would be nice. What's he going to do when he gets to Penn Bay? Be on a Lifeline going on? So I mean, why spend the 45 minutes messing around? Whatever. So So oh well. But we don't have any baby calls in St. George. We have little ladies who fall down and all that kind of good stuff. We don't have too much of that, luckily. But anyways, so assessment, when you walk in the door and you start a call, basically, pretty much somebody should pop on the oximeter probe. And kind of important to make sure you got ones that do work and match up to your monitor and all that, or you got the handheld ones, whatever it is, just make sure you get something that's going to work for kids. It's very important. The little $35 Amazon ones that some people work for me, want to carry around, they don't work on kiddos. You need to take one type of thing. And of course it needs good blood flow, warm fingers and toes, and a quality sensor, and all that stuff right there. It also can read carbon monoxide, so if anybody else in the house sick, yeah, he's not feeling good, he's got a bad headache, he's taking 3 Tylenol, well, bingo. CLC does it, Augusta does it, maybe you guys do it here, but in the first in bags, we actually have carbon monoxide monitors.
Yeah.
And once you got them, it never happened, you never needed them, but it's just a good thing, you know? It's, well, it's Murphy's Law, right? As long as I got it, I don't need it, you know, so. Because pulse oximeter will read carbon monoxide just as well as it reads saturation levels, and 95 to a kid is like 90 to an adult. Many adults can handle 90, many adults cannot. 95 is not good for a kiddo. And are they sick or not sick? So normal mental status, they may be sick but not unstable, concerning, going on the list to unstable, and if the kid, isn't got enough energy to even keep his airway open and all that stuff right there, and that's probably the worst situation, and gotta work fast on that one. So checklist, we're looking at things with a respiratory problem. Rate rhythm's important. Deep, shallow, are they little puffs, they full cleansing breaths, whatever. Does the chest look pretty good and move symmetrically? Open the chest up and take a look. And the flaring, retractions, accessory muscles for breathing. And of course now at this point, you should have the oxygen flowing. You know, a certain point like, I think I see, I think I should, maybe I will, I'll start that, I'll keep asking questions, the mask is on, the stuff's flowing, and like, you know, you got an oxygen mask on a kiddo, and like a minute or two later, the saturation hasn't got much better, the kid's not looking much better, and probably, you can almost say at that point, I think they're respiratory failure. You know, that's kind of important thing.
Your fifth one
I mean, it's just
down,
like,
Kevin, needs an S.
what's that?
Your fifth one down needs an S.
Yeah,
You have dough.
yeah, exactly, yeah. So, any wheezing? Walk in the room, you can hear the wheezing. Any grunting? Grunting you can hear easily. Another sign of respiratory failure. And of course, skin color, temp, things like that right there. If you look at the pediatric assessment triangle, the bottom leg of the triangle was circulation. Circulation goes back to distal extremities warm, dry, detectable pulses, or just central pulses. Okay, that's kind of important part of your circulation thing. There used to be some great videos online from pediatricsepsis.org, but they took them off. The website's still there. They had kiddos that were really septic and hypotensive, hypovolemic, all that kind of stuff, and they'd rig up a 50 ml syringe and three-way stop cock, and you sit back and you look at the kid's heel. They'd push the kid's heel in, and it'd be like still pale, bluish, purplish, and then a few minutes later they put a few more shots of the normal saline, things like that, through the three-way stop cock, and come back a moment or two later and start kicking the kid's heel, and all of a sudden, like boom, the colors spring right back. A capillary refill. And what was also incredible with that video, it was so great because in the beginning you had a fuzzy kid. It's almost like, is a kid grunting or crying? I'm not really sure. But the kid was extremely irritable, and once like the third dose of normal saline went in to match the calculation, and the kid all of a sudden kind of like purring, nice and happy and smiling, and like, what a big difference just listening to the kiddo as well as see what the kiddo's heel looked like. You know, it's kind of cool, you know. But that site took the web videos down. So anyways, a failure, it's a judgment call, but the thing is, judge on the patient's best interest, and if you did bag them, and whatever, then just basically do it, you know. I say about adults a lot. Some of you have been following me around, I say the same thing over repeatedly. It just makes such a big difference. Like in adults, if you think you need to bag them, I do. If they don't reach up and grab your hand, the mask off their face, then you're saving their life. Pretty simple. Okay. And of course, out there. So, anyways, assessment pearls. So I mean, EMS as well as like tachypnea is a first sign. But anxiety, fever can also cause pain. That would be not a respiratory problem. Tidal line for kids 6 to 8 per kilogram. I'll go measure on that. Don't worry about it. Basically, if I get a BVM, I don't go overboard and go squeezing the dailies out of it. We were taught to do that many years ago, not more. And kids will use the diaphragm more than the muscles and the cosmos when they're in distress. And the key thing is when they're in distress and work of breathing, let them sit in mom's arms or somebody's arms, lowers anxiety. Try to keep them calm, because work of breathing is increased by 32 times when they're crying. And laying flat's bad. And you know, in this business, we're kind of like the mentality of laying them down and all kinds of stuff, so I can look at them and get the Braslo tape out, which I stress very heavily is so important. But if the kid is that bad in respiratory distress, like they can wait a few minutes. And infants can't position themselves, but the older children can. That's an important thing to look at. So, you know, little tot, sitting in mommy's arms, and you don't look too happy, does he? You know? That's the best position. Or a child can look at you and It's attentive alert. So this kid's in distress, maybe not failure yet, getting treatment, getting nebulizer treatment. Of course, being in mommy's arms, little kitties like that as well. Grandkids like being in grandpa's arms too. I don't know. I mean, I got 8 grandkids now, so they're all age variations. But if you have to start bagging a kiddo, if you need to, one of the better things to do is to get the body up at an angle, reasonably like this direction, like around 30 degrees. But then try to get the head, the face, with the ceiling, okay? That opens up the airway. That's also like a perfect position, actually for intubation, all kinds of other stuff, moves the airways up and along, not to intubating kids, but adults and everything. But you got a shoulder roll and a headrest. That's the best position. If everybody remembers, the CPR training is not to pull the head back too far because you'll close off the airway. I don't know how true that really is. I've never seen that done or happen, but remember that in the CPR book? Go back too far, you close off the airway, whatever, so who knows. Anyways, nose to chin axis is parallel with the ceiling, where the kid's shoulders, body is going up like a 30-degree angle. And that's something important about bagging. So stridor is one of the issues, and it's a high-pitched crowing sound, and pretty much it's a restriction in the upper airway, and it's not a lung sound, it's an airway sound. It could be from a viral problem, bacterial problem, yes, it can be from a bee sting problem, a peanut allergy. Had a little 1-year-old Express Care in Augusta a few weeks ago, and mom and dad brought him to Express Care, Maine General, because when I go to the hospital, right? And the kid had peanut butter crackers. This kid had big red lips. And like, wow, he had crystal clear lungs, nice sat and everything like that. And like, did you get MIPI? And people, the doc at the Express Care said, no, he doesn't need that. Okay. From a stretcher, taking him down the road, around the corner at the Alphon Center for Health and all kind of stuff. And first question was, why do you give him MIPI? Because your doctors over there said not to. So, you know, so, oh well. Anyways, high-pitched crowing from stridor can be peanut allergies. Kids can have that. Could be bee sting thing type of stuff. That's maybe later on in life. Infants can have that. The peanut one is definitely one. It can be a foreign object as well. We can't tell that, no doctor without an x-ray type of thing. But it's really an upper airway obstruction. And this chest x-ray here shows a classic steeple sign, where the arrow is that the airway is swollen, or other reason why the kid's sick from something, viral or whatever it is, type of stuff. That's where the airway is given the whistling sound, okay, the stridor. The best way I always describe stridor, I do have it on my iPads in the car. I got one of those lung sound things on my iPad, but like, you know, when you're in grade school, which was a long time ago. I remember on field trips in grade school, long time ago. Like, remember putting grass between your thumbs and the end line and making noise and all that to piss off the teacher? No, so it's kind of like stridor, okay? You knew that when you were a kid? No, okay. Okay. Whatever, okay. Things we did back in the 50s or 60s, oh well. Okay, so anyways, that's stridor and high-pitched crowing sound. And also, those kids trying to pull air in are actually going to have a chest that's going to cave in. The muscles are working hard to pull air in, but there's a restriction, so their chest caves in. That's pretty close, you know. I can't do that too much, I'm going to choke, okay? So, stridor, our best option there is going to be a nebulized epinephrine in 1 ml, the 1 to 1,000, which is 1 milligram. 2 mLs of solution, saline, dumped on the nebulizer bowl, and the thing is, when you give a kid nebulizer medication, what I've always done is that you take out the T-piece type thing, and take the plastic bag the whole thing came into, and I put the plastic bag over one end of it, and I stick the mouthpiece over there. It shuts that end right off altogether. So now the oxygen comes up to the nebulizer bowl, atomizes the stuff, and blows it out the pipe. So now I can point in the kid's face, and he's going to get it. It's not going out 2 ends. The kid, you can't get the kid to hold on to a mouthpiece and suck it in, okay? Taking the nebulizer bowl itself, having it come out of there is okay, but I have that little pipe that can aim at the kid's face. I've done that, it's been effective. So otitis is another issue. It could be a bacterial infection and so forth. If you look on the left-hand side, you've got a gap there where the airway is clear above the trachea, and lateral X-ray and stuff right there. And you look on the one on the right there, it's pretty much closed off. That's going to be a stridor, a kid with stridor. But again, for us, we don't get wound up into the whys and this, and what's the X-ray going to look like? No, I need this, I need laptop. But you know, what really is that? We got a kid in distress, probably trying hard to breathe, and the BVM effective in this? Not really sure. One trick that's been done for adults is that with the white Ambo brand BVMs, you can spin the valve off the top. The little red valve comes out, the little red disc comes out, and you can dump a butyrol down inside there, put the valve on, screw the top back on, shake it up violently, and then start bagging somebody, getting a butyrol into them. It doesn't work with duo neb. It's just something that just sticks to the side of the bag, but the butyrol works like a charm. But if you have the duckbill type BVMs, they're hard to do with those. Some of the if you look at the valve, it's like a little duckbill, closes up and everything. Those don't work very well, but the Spur Ambo white silicone ones are those that the butyrol dumped in the bag and shaken up violently, and all that stuff works great for getting fluid and medication to somebody to open them up. So anyway, main EMS protocol, that's what we do. But even for medics, it requires online medical control. And the key thing would be making sure the kid doesn't have any pre-existing cardiac conditions. So you could say that, we asked mom, and mom says there's no known cardiac conditions. All that stuff. And I don't know if that's going to work. I don't think it will. Yeah, okay. I try to embed my YouTube things and that, and YouTube's not cooperating anymore. I tried to embed it with the proper way to embed things, and it didn't happen. So here we go. Here's somebody here with the kid on the left, though. He's looking like help me. What's the kid on the right saying? I'm dying. Yeah, okay. And you look at the way the chest is caved in. I mean, the sternum's almost touching the backbone. You know what I mean? So right now, where's our airway obstruction? Upper, yeah. Okay. The funnel is closed right down, and the I got somewhere. I got my little toy here. I got so. Well, that's upper airway obstruction. I'm talking about lower airway obstruction. We got pediatric asthma, and this one, yeah, the animation happened. Cool. I didn't think it would. It's great. And reactive airway disease, asthma, all that kind of stuff. It's kind of we've all seen that before. And pharmacological treatment. It is better to have a spacer if you have it. That way, again, a kid try to coordinate using a ventilator, or an MDI, Ventolin type thing. It's tough to do. Tough to, I know, yeah. So spacers are big. There are spacers out there that the hospital, on the medical supply, like Boundtree, there's a spacer with a kiddo's face mask on it for like $80. And on Amazon, they're like 15. So if you've got, now the core thing is for the EMT basics, number one, what's the first most important rule? Well, it's the right patient, the patient name is on it, okay? And kind of why is that important?
Because you don't want to be giving somebody else's
Okay,
medication.
okay, well, okay, but here's one, okay? Okay, so little Johnny has a peanut allergy, and someone nearby says, well, I got an inhaler, you can use mine, and they use this one here, okay? And this one is Combivent, okay? See that little flag of Italy on there? Okay, you know what that is? Italy, Ireland, something like that. This is Combivent, and Combivent is Duoneb. In this form, there's peanut oil in here. So if a kid's got a peanut allergy, he's not breathing, he's wheezing, and you give him a peanut oil medication that can solve a respiratory problem that's going to create a problem, you'll kill a kid, okay? That'd be nice about it, I should say, it'll be taped right. He'll cause great harm. He'll cause great harm, okay? Right. So that's really is why it's very important that you have, I don't even touch that because someone in here could have a peanut allergy. That's not that important, okay? Whereas this right here is plain old albuterol, Ventolin, albuterol, all the different brands there. So it is important to know which one you got. The spacer was a cool thing. And it was kind of my choice. I'd have a spacer and an ambulance pediatric kit because it could work out pretty well. So anyways, in asthma, we've got the lower airways. The lower airway is going to be the bronchioles on down. Now, in the bronchioles, we go trachea, bronchus, the bronchioles, to the alveoli sacs. And in the bronchioles, they're conducting airways. There is no real gas exchange occurring in the bronchioles. But the bronchioles do have muscles, nerves, blood vessels, and all kinds of things like that. So they can get infected, inflamed. In pneumonia, there's also a little tiny cilia action that can sweep stuff out and all kinds of stuff. So a lot of things can happen in the bronchioles. And in lower airway obstruction, as you see in the little video illustration here, the airway passage gets narrowed, and it could be muscular, it could be yucky sputterball, mucousy, white dead blood cells from an infection type of thing, all kinds of stuff, as well as reactions to things like peanuts, pollen, things like that as well, and the airways close right up. And adults who've got a much larger airway can take a reduction in the airway diameter, whereas kids really can't tolerate that. Okay. And again, with an asthmatic type of thing or lower airway obstruction and bronchospasms, the primary treatment is going to be pharmacological to try to open those up. The albuterol is one nebulizer, important. Epinephrine is also going to be used to reduce the swelling in some cases. And of course, magnesium's there as well. That helps. And all those different things may be the issue. And like I say, using that face mask for kiddos may be a happy event if they have their own inhaler, own DI. So in the main EMS protocol, if things are really not going well and you're in basic EMT, again, if needed is kind of like, well, what would that be? If they're falling apart, not doing good, respiratory failure, everything's going bad, help's not coming for a ways, you're ways out and everything, get out to BVM and start ventilating them, okay? And the best thing to do is try to work with someone's respiratory rate. Pitch them up, sit them up, like you're a first responder in Jefferson, Chief, and like you can grab a bunch of pillows, put a kid on the couch, and sit the kid up a little bit, and get a BVM and muckle on and start trying to work with the kid's own effort. If you try to fight the person's effort or don't time it right, you're trying to blow air in, they're trying to blow air out. That's not fun. That doesn't work too well. Trying to watch there, open the chest up and look. If you see the retraction, and when you see that, squeeze, 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 squeeze. Follow it in, follow it in. Pneumonia, bronchiolitis, respiratory syncytial virus, things like that can be starting off with the common cold symptoms. They could have caught it from somewhere else, who knows where. They could be wheezing, trouble breathing, not feeling good, fever, labored breathing. And again, this is the kind of the thing where things are starting to happen. They're not bad. The kid looks sick. Kids do get sick. Kids are sick on a regular basis. And like mommy's going to be like, well, I'll call a doctor. I can get in this afternoon. Okay, I'll be there at 3 o'clock. Or it's 9 o'clock in the morning. And by noontime, the kid's in deep trouble. They're calling you. Or the mom's racing down the street trying to get that doctor, or whatever that's happened, all that kind of stuff. So you'll know that. That's a common thing. And again, pneumonia, being an infectious type thing, they're pretty much the white blood cells in the body race to that site of infection and go after the bad offending little booger there and produce pus and white blood cells and stuff. And that's that's kind of what you see in the screen in the X-ray shot. Okay. It's kind of the pus and white blood cells. And remember too, that in the lungs have got a substantial, massive blood supply. And when you prick someone's finger for the glucometer, what do you see? Big red drop, right? Little red drop. You see a red drop, right? But in that red drop, 40% of that red drop is actually water. Okay. So there's a lot of this, in the lungs, when you've got so much fluid going through the lungs in volume, including that water as well as also white blood cells, electrolytes, things like that, not just red blood cells as well, even though we see a drop of red blood. The white blood cells are in there, and they're going to go to work after the bad item, the bad offending virus type of stuff right there, and when they do their magic and get killed off, that becomes the thing that we call pus type of stuff. And the body can produce that, cough that out sometimes. Adults will. So if you get somebody who can make productive cough and have a big green, gray-looking, yucky ball of yuck come out, and you can save it, that's kind of nice, in a sterile container. That's for pneumonia type of stuff. Okay, so cystic fibrosis is another tragic one that happens out there, very rare. And a gene that was defective on child's DNA makeup, everything. They're missing a chloride molecule, and those ones, these are out there. There's one in Knox County that I know of. And pretty much what they've got is a tough, mucousy, thick linings in the bronchioles. They have a tough time trying to get it out. And with them folks, basically what you're kind of limited what you can be doing. It's going to be an albuterol nebulizer, open up the airways. But even importantly, if you're not at an ALS level VSEMT, you can still take a nebulizer, still proper. In your protocol, in some of the protocols it says you used humidified oxygen. How do you humidify oxygen? You can use one of those humidifier things, right? Okay. You take a nebulizer, you dump normal saline in it, and you blow cool mist at them. And that's great for croup. Okay, can be helpful maybe in some burns or airway burns. And in cases like this right here, having that mist helps get in there. It loosens up the thick, stringy yuck that's accumulated. They can't expel on their own. Helps loosen that up, and they can cough some of the stuff out. The albuterol is important. So pretty much looking at literature, and I'm going to talk to Dr. Pei about this should be in the pearls for next protocol update. Would be albuterol followed by a cool mist saline nebulizer, just to help them move all that stuff up. And open up the airway. Let's get the stuff moving now. Get them so they can cough it out. I know a couple of females made it in their 20s and passed away from it. I know one male in Hollowell, because mom used to work with me. He's in his 30s and still doing okay. He showed up in his court papers once, so I guess in the arrest logs, I guess he's doing okay. Things I can say up there, I can say down here, I can't say up there, whatever. So it's a pretty tragic disease, but it's rare, but they're out there. Ready? And sick child case. So here we go. It's a kiddo, 4 months old, poor color. Things didn't look right. And finding out when you're doing an infant call, finding out is a kid bottle fed or formula fed. That's important. Are you hunter-gatherer information? Are they filling up diapers, bottle fed, all that stuff? That's all important. This was, the baby was bottle fed. And arrival, we had a nice temperature, very, very fast heart rate. Okay, for 4-month-old, 140 is fast. Look at the saturation. Okay. And blood pressure looks okay for the size of that kiddo, right? Looks kind of okay. When you look at kiddos who've got poor color and a rapid heart rate, they can also have congenital heart defects of circulation. When the ductus arteriosus, the little links there don't close off, things like that. So one of the things that the docs look at is a point of maximum impulse. Easy to do in a guy, you can't do in a gal, but you can sometimes find out the right spot right in here somewhere. You can pretty much feel your ventricle. Tough for you gals to do, but it's easy for guys, okay? That's a point of maximum impulse. So in a kid, if you can't find that, then like, oh, we get a circulation issue, we get a cardiac issue. Could be, for us, whatever, okay? But anyways, there's a nice strong ventricular sensation there. Of course, on a female that age, I get it, no doubt. And no murmurs, and I have found murmurs before listening to kids, and like, wow, what a squishing sound that was. Anyways, clear lungs, but a very cyanotic appearance. So you think about the point of maximum impulse, just for learning purposes. The ductus arteriosus is also a ductus venosus in the lower end. That's the maternal circulation bypasses. And when the child is born, clamped off, and fresh air comes into the lungs, the ductus arteriosus starts to close off. It may be a little slower closing off. You may have a newborn who may close off normally, still an hour later, have blue hands and blue feet, where everything here is pink. Actually, I got a picture of a kid like that. I don't have this set here, but I got a picture like that. And you know his mom and his dad, most of you. Anyways, so sometimes that can happen, and that can be an issue for kids. It can also be an issue with kids when there's also a hole in the side of the heart Fremont Valley, you know more, correct me if I'm wrong, okay, but sometimes that circulation may be all that's making that kid stay alive, and the Angel team gets here, all kinds of stuff, if that's what they think is going on with ultrasound or x-ray, they may give prostaglandin, a hormone, to keep the ductus arteriosus open, because that's why the kid's getting normal circulation when it gets to a surgical repair and all kinds of stuff. Those things do happen. But anyways, the ductus arteriosus and the venosus close off on circulation. But anyways, this kid had, on the x-ray, crystal clear lungs. Oh, yeah, cool, okay, nice. No fluid, no crud, no everything. Nice crystal clear. I think it's supposed to be actually the actual case. And got dosed with oxygen by non-rebreather with no noticeable improvement, no ventilatory deficit. And once the high flow 2 went 90, sat went up there, okay, cool. Everything else, chest x-ray, UA, and CBCs are all remarkable. ABG is the kid was slightly acidotic. CO2 is normal.
What's the actual respiratory drive?
What's
Does
that?
Does this kid even have a drive at all?
Yeah, yeah, breathing fast, yeah. Okay. And the kid's oxygen level, though, dissolved oxygen in the bloodstream, okay, was 300, which is like 3 times the normal. Normal is only like 80 to 100, okay? Now, remember we're going to talk about the glucometer, the blood sample comes out. When we get a drop of red blood, and we stick a glucometer on it, again, 40% of that's still fluid, water, white blood cells, all kind of stuff. It's not red blood cells. When you take an oximeter and read your finger with an oximeter, you're reading oxygen bound to red blood cells. Okay.
If you don't have enough red blood
But when you get an ABG, okay, now an oximeter is not diagnostic. It's a tool. It's a great indication, pretty much on the ballpark, almost accurate. But it's not really, when the docs in the critical care unit, things aren't really going well, they want an ABG, okay? And when they take an ABG, and they want to find out how much oxygen is in the bloodstream, they're actually reading it off of the 40% water and serum, white blood cell mix, not the red blood, because they can't fracture red blood cells and count how many oxygen molecules around them. An ABG, the saturation is read off the serum. Interesting, you know what I mean? So it's kind of like, yeah, 2 different, but the values are going to be the same, because if you've got that much oxygen packed into the serum, the red blood cells will have it as well, okay? So anyways, this kid's got tons of oxygen in the bloodstream, but still, sat-wise, not doing very well. So this goes into something else that can go with like cold patients, acidotic patients, poison patients. It's called the dissociation curve, and pretty much it's like a left shift and a right shift. So if someone is, if they're too cold, they may not be able to load oxygen on. They're too acidotic, they can't offload it. And it's really, oh, okay. Pretty much the curve goes back to your properties of the bloodstream, whether it be acidotic, alkalotic, and all that. And,
This side.
okay, cool, but I think of that earlier. This thing poop died on me. And so like in one condition, to the left shift, I think I got it right, is that you can load plenty of oxygen on the red blood cells, but you can't offload it to the tissues. And like the right shift means that you can't load on the red blood cells, but the tissues are screaming for it, okay? Did I get that right?
Yeah, yeah.
I don't know.
You have that right? Okay. Okay, all right. You're my backup.
Sorry.
Okay. Okay, so anyways, this kid had a thing called, I can't pronounce it, methemoglobinuria, or it'll be up in a minute, okay? And above 20% level of ferric iron in the bloodstream, they're gonna have cyanosis, dark blood, chocolate color almost, they have headache, nausea, confusion, and all kind of stuff, which you won't have a kid verbalize that. And pretty much elevated levels of methemoglobin in the blood, and the blood on the right is nice and red, the blood towards the left is almost like a rust color, because there is iron in your bloodstream, the heme molecule, all kind of stuff right there. And of course, affinity for oxygen, so you could load on plenty of oxygen, but you couldn't load it off to the tissues. And what it come down to being is that this kid was getting heavy doses of Oragel. Okay. So this is one of those things where I talked earlier about being a hunter-gatherer of information. I lot of things that may not seem like a big deal actually matter. And like sometimes certain little minute little facts fly by, it's like, oh, I didn't think about that, you know what I mean? You know, like sometimes the hunter-gatherer of information, okay, the Dr. Phil can hold hands and make everybody feel good. The Dr. House is gonna sit back and be the hunter-gatherer and the critical thinker of like, things don't look right, they don't look bad at the moment, they don't look right, how come, you know what I mean? Medication's missing, kids, you know, on the counter, they're messing with the cleaning supplies. I mean, they've out in the, you know, I remember a little kid, we were out in the backyard screwing around because somebody had found sulfur, we melted it in spoons, and took a whiff of it and almost died. I mean, you know, it's kids do crazy things, whatever, you know. So anyways, for that kiddo, in this case here, in the case history, methylene blue is administered over many hours, and it corrects the problem with the blood, and everything has a happy ending, you know. Want to take a break for a few minutes?
Yeah.
How much time we got? Okay, cool. Sue's got some treats. Get a little drill at the end, childbirth stuff, when I play with that song. We have just got a few little things I do. And this, like I said, is from my smorgasbord and stuff I put together. And this is from the Peers program. And here we go. Look at his retractions, okay? So when is the noise occurring?
Inspiration.
Inhale, okay? So an upper airway, well, basically, that's the discussion, so. What do you think it is? What's initial impression? Remember when you walk in the door, what are you seeing?
Sick kid.
Okay, it's a kid, okay? And something I didn't mention earlier too is that someone's been sick for hours, if not a day, who's working hard to breathe. Remember talking about stress and energy consumption, stuff like that right there? They can also stop breathing because of just plain old fatigue. Adults do it, right? You know, kind of stuff right there, so kiddos can do it. So really, breath sounds, it wasn't really so much a breath sound, but, okay, look at the monitor, see what his numbers are. And, okay, so I don't know how much, what he looked like, maybe like a 3, 4, 5-year-old. So that's a very rapid heart rate. Stats kind of okay. Pulse does match the heart rate, that's kind of nice. Respiratory rate's 32, yeah, BP is good, so. I mean, those numbers look okay, but really, what's he look like?
He's compensating.
Oh, yeah, so yeah. So the stethoscope down here, I'm kind of hearing a normal, but I'm hearing the, what do they call that word, reflected, not reflected, the transmitted, whatever it is. Anyways, the noise up here is we're listening to down here. Okay? That make sense? Okay, quick. Okay, on the bottom end of the, I didn't talk much, a whole lot about it, I did mention it, the pediatric assessment triangle, bottom half of circulation, okay? And really it's pretty quick. 1, 2. Okay, that's good. Okay, so he's circulating well. Okay. I don't think I was taught to do years ago when I do it and upset some people, but I kind of also, I look under people's eyelids a little bit. And if I can see pink, you probably can see my pink, you know that red blood cells, or at least there's a bunch of them there, they're floating around, they're moving, that's kind of good. And if you see like a gray, that's early cyanosis. If you see white, that's pretty much lack of perfusion, shock, anemic, whatever it is, so kind of like an easy way of doing it. And I get people I work in the city and I kind of like, you're always poking people in the eye. Whatever, okay, yeah. Oh, well. energy, tired, exhausted. That's a sick kid. Probably other things are going on as well that are making this kid sick, weak, whatever words you want to use, lethargic, and got there as well. So he may have started off hours earlier with kind of like I'm not feeling good, help me out type of thing, but they don't say that because they're too young to say that. But I mean, he's going into the stage of like distress, really bad distress, going into failure, you know. Does he need a BVM yet? It kind of triggered, right? So no, not yet, no, okay. What could he use? Probably some oxygen and epi type of stuff, yeah, you know, so, okay.
That was a pretty quick respiratory rate too, I think.
Yeah, 32 a minute,
Yeah.
yeah. Okay, so, all right, we did that, all right, we did that, okay, all right, Strider, open. So, okay, he's attentive. He probably answers to his name. Yeah, okay, yeah, you know. Yeah. Okay, what's the respiratory rate? Fat, yeah, I don't care, I'm not gonna do this, but pretty much it's fast, okay? So, okay, so respiratory distress, is he heading for failure?
Yes,
Does he need a BBM yet?
he's already doing the head bobbing thing.
Yeah, I don't think he's a BBM candidate yet, but that's my opinion, but then again, if you think he does, then just go ahead and do it, don't, you know. You think you should put a collar on the person, do you put a collar on him? Yeah, we take him off the hospital, right, you know what I mean, so yeah.
Of the two so far, would you have given either of them humidified oxygen?
Wouldn't hurt, you know. Okay, so right now he's on room air, which, why? Okay. He's somewhere where somebody's got a camera running, so I mean, why is he on room air? That doesn't make sense in my book. And there was some stuff in an old PALS tape where, like, if you watch the poor kid suffer, you actually almost ready to get out of the chair and strangle somebody. You couldn't because it was DVD. But then they said later on, like, this is a loop thing, so don't get wound up because it's a loop, you know, or like, you know, whatever. So, but I mean, the kids in room air, that's, you know, it's not the best thing. So let's listen to his lung sounds.
Is that
Yeah, it's probably gonna be more of a wheezing type thing. When you take a breath in, your chest diameter expands, right? Take a real deep breath and your chest really expands, okay? And your trachea is pretty rigid, but the bronchioles expand as well. So when your bronchioles can open up a little bit, increase in diameter. When you relax, the passive phase of breathing, that's when the wheeze on the exhalation occurs, because now the airway diameter is reduced, and any type of vagration, turbulence, plus whatever is in there, okay? Asthma, or there's all kinds of stuff can be in there, okay? Okay, that's why you can hear the wheeze on the exhalation. What's cap refill gonna be like, you think? They don't show us, do they? Oh, okay. Oh, well, all right. I mean, his stomach's pulling down to increase the chest diameter because he's in distress. He's not getting air in there. So rapid heart rate, sat and Lutheran rate. Yeah, drooling, yeah, good point. Yeah, okay. stomach, chest wall, okay? Okay? Trying to breathe out against a closed glottic opening. Closed glottic, you know? And normally for all of us, and when things are going all right, normally, the body actually has PEEP of about 5. So we go to use a CPAP, we said like start like a 10. We're already at 5 normally. And that's where your alveoli don't collapse. Okay, so the body does self-PEEP to a certain point. Now the body's self-PEEPing even more when you hear the grunting. So anyways, this kid, what's your impression of this kid?
Very, very sick.
Well, he's in the hospital, so at this point, what we do in the field, but he's on nasal cannula. He's grunting, he's probably septic, he probably has pneumonia, he probably needs antibiotics, all kinds of stuff. But for us really in the field, if we can improve oxygenation, making him comfortable and reduce the work of breathing and reduce the fatigue, that's very important. If he's been like that he started like that last night, then it's not really a priority in your care plan or your thoughts of what you're doing, but you know, at some point as you're on the way to the hospital, things are a little under control, and you get like a second to do something, grab a heel stick blood sugar. Heel stick's better for kiddos type of thing. See what it is, because if they've been working hard and getting stressed out, and you may find something that like 9 times out of 10 be no big deal, and the one time would be like, oh wow, he's down like 38. You know, kids can dip down to like 50 and 60 and be kind of okay. So I don't really worry about that too much. If you could find a kid who's got respiratory problems and they're like at 60 for blood sugar, and you're 10 minutes to hospital, and basically just make that part of the report that blood sugar is 60, not something to worry about correcting in the field. But you can, of course, make your own decisions. You follow your protocol. Don't listen to everything I say. So a little tot that size. He looks like about what? He or she looks like about maybe 2 or 3 months old, 4 months old maybe. You know, good color. Looks like it's well nourished, so that's kind of good and everything. So you got air going through spotted balls of liquid. Okay, so to me it'd be kind of like probably they had ears. Pneumonia, I think pneumonia, because probably chances are they don't tell you, but if you touch the kid, it'd probably be like, you know, he's warm, you know, burning up. However, that doesn't mean everything either, because a kid who's burning up gets chills Tylenol, fever comes down. That's kind of good too. So it may not be, if they gave him children's Tylenol an hour before, then temperature may not be an accurate thing to look at, you know. And cap refill. Yeah. Well,
Right on the border.
yeah, okay. I think it's probably a good idea to have pacifiers in a PD kit. When I go in the stores and look at the pacifiers, none of them are clean, none of them are sanitary, none of them are wrapped in plastic, sterilized. So probably if I could sterilize one and wrap it in a baggie or something like that right there, it probably would not be a bad idea to have one, especially if you're transporting a kid out of main med. You know, put a pacifier in the mouth and kind of keep them happy, just a thought, you know. And okay, so that's, okay, I think we're done with that one there. Okay, yep, all right, we're done with that stuff. All right, cool. Okay, so kind of goes over the stuff I want to talk about, the respiratory stuff. Yeah, I think I covered it all, but any questions or any? Okay, cool, okay. Medical problems can occur as well. We're gonna have sick kids. sick kids with medical reason can also maybe presented as a respiratory problem, but there's more to the story sometimes. Poisoning certainly is a biggie, and those don't happen all that often. And I know, like as a kid growing up, and even when my kids were little babies, everybody had a syrup and Vipicap in their medicine cabinet. And the kids took things, you gave them that, and up it all come and all that kind of stuff, and now it's not a good thing anymore. Poisoning is a biggie, and when you've got the sick kid, nothing makes sense. Kind of like that's when you start looking around and start being the hunter-gatherer of information, and Dr. Howe, thinking it's just the usual situation, what's going on, type of stuff. We look at shock states in kids. We can have sepsis, which is a biggie. The kid with pneumonia and untreated and sick and septic. But also in the beginning, when the fever's up there, the body's reacting to it, white blood cells are racing to the site of the infection, they're breathing fast, working hard to breathe, and that's also known as the warm phase of shock. And they can be warm to touch, temperature can be normal if not elevated, the fever up and all that. And as the sepsis or the infectious, whatever is in the body continues through the body's reaction, known as systemic inflammatory response syndrome, starts releasing histamines, all the little hobgoblins and stuff, and start wreaking havoc on the whole vasculature. And your vasculature in your body that was kind of intact, a good pipeline, now becomes a very, very leaky pipeline. And kids start having something they call it like third spacing. You start seeing puffing, all that. You start seeing blood pressure dropping. You see, and that's kind of the cold phase of shock. At that point now, you're in serious trouble. I can't recall at all any kind of that ever happening on the field, except with one lady who was in her house for a couple of days, had a pretty bad UTI, laying in her own urine, no blood pressure, like 60 over nothing, 2 bags of fluid. She died like an hour after she got to mid-coast. And that was like cold phase of shock, septic shock with the UTI, and only because she was lived by herself and no one came and looked at her. And she was delirious, didn't make sense, and you just touch her, she was a refrigerator. But that can happen to kids as well, because kids can't voice. They're not feeling good. They're not feeling right. Things aren't going good. Distributor shock is, of course, an important one. Big thing with that comes, of course, is going to be the idea of bee stings, things like that, allergens that can cause the widespread systemic vasodilation. Okay, which also can trigger the swelling of the tissues in the throat, giving us epiglottitis or swollen throat and stridor as well. So distributor shock's in there. And of course, typically with that, we got the EpiPens to solve that, hopefully to get that taken care of. But sepsis is the biggie. And also, there are many people out there, I wouldn't say many, there's a significant number of people out there who are not vaccinating their kids. And the reasons they give are reasons that I can't sit back and say they're wrong to think that way. So little Johnny doesn't get vaccinated, he's 5, 6 years old, he steps on a nail out in the barn. A lot of these folks may be the rural homesteaders types that try to stay away from the spoils of modern man, TV technology, iPads, and all that. I tell you, nothing wrong with their lifestyle. Probably live longer than I live. Little Johnny has not had their immunizations, steps on a nail out in the barnyard, gets a bad case of tetanus. The kid is going to be unresponsive, seizing, could be a warm fever, and all kinds of things like that right there. So again, that's going to be the hunter-gatherer of like things that have gone wrong. And like I talked earlier about all the things you asked about a kid, immunization history is important. It may be a sensitive topic with the parents, caregivers, but it's kind of just one of those things you should be asking as your hunter-gatherer mode develops. You find a lot of kids coming in immunized at the hospital. Okay, that's good. But it's odd, you've probably seen the nursing magazines, right? A lot of discussion about it, because people.
It's huge in the school system.
What's that?
It's huge in the school systems.
Is it? Oh, okay, yeah, dehydration is another biggie. That's an important one, and like newborns that are nausea, vomiting, diarrhea, who are like 4 or 5 months old, they'll have signs of dehydration that are not good. Blood pressure, of course, is, and the squirmy, squiggly kid, it's pretty impossible to get a blood pressure. If the kid is squirmy, squiggly, resisting you, fighting you, they probably get a good blood pressure. I'm okay with that, you know. Really, can I ever get one, and sometimes on the way to main med, I may not get one down until the exit, when the kids calm down, I can put a blood pressure cuff on their leg, and because they're tired, they're sleeping, and by the only time, but normally it's hard to get a blood pressure on a kiddo. The kid who's totally unresponsive, limp, and somebody's bagging them, you probably get a blood pressure on them, but there's probably no blood pressure to get. Anyways, shock index is a concept that goes back into the things of the damage control resuscitation and the lethal trauma triad principles. You know, the whole things of trauma care now is kind of like taking a whole different change in direction. And like PHTLS book is kind of nice, but even the newest version coming out soon, you'll find my name inside of it too. But that stuff's behind. The newest stuff coming out now really is important now. Is going to be on damage control resuscitation, limiting massive doses of any kind of doses of IV fluid to get his blood pressure built up, stop the bleeding, get him to a trauma surgeon. Ringers is much better than normal saline. That stuff's coming out now for a year. And you know, if you get some time on your hands, you're bored, Google up the YouTube things on lethal trauma triad. And that's about a couple of 15-minute ones in there, which are great to learn. And another one that's really good, but it's an hour long, is damage control resuscitation. And there's some lecturing doc at Johns Hopkins who talks for like a whole hour about it. And you sit back and understand a lot of things that are really very simple to understand. I didn't have trouble understanding it. It's not really all that big complex, but like it's so simple, like wow, we've been kind of going the wrong direction for many, many years doing stuff, you know? So these are things to learn on your own sometimes. The shock index is that like, there's a pediatric adjustment to it, but pretty much the idea in shock index is that someone is injured, belly's scraped up pretty good, they didn't have a seatbelt on, hit the steering wheel, kids aren't restraining the car seat, whatever that is, just like abdominal trauma, maybe bleeding the liver, the spleen. If you take their systolic, it's only like, say an adult, it's only like maybe 110, but their pulse rate's 140, they're in compensated shock. And normally you say someone's blood pressure is 100, are they in shock?
The systolic?
Yeah. You know, they hit 60, 70, like, oh, they're in shock, like, all right, you know, pouring the fluid, okay, right? Well, you start getting like a higher pulse rate than the systolic, they're in shock. They're in compensated shock. And adults can compensate for a while, pull in some reserves, tighten the vasculature, right? Kids can't do that. They can pick up the rate, okay? So there is a pediatric adjustment, basically it's like 0.9 times the number you get. And after a while, it's like, you know what? I can't do that kind of stuff. I'm not that complicated. I can't do that. Pretty much like if their pulse rate's really fast, the blood pressure's kind of okay, adult or kiddo, they're in shock. They're in compensated shock. And you know, at that point there, time to be feet to the hospital. You know. Oh, I had a clicker here somewhere too, didn't I? There we go. Okay, cool. Okay, good. Okay. So in shock, pretty much, we find somebody who's in shock. And you know, the thing is that if I had someone whose pulse is racing, they're kind of pale, they have slow capillary refill, I got blood pressure that maybe seem kind of okay, I'm still going to call up the doctor and say, look, how about we give them at least one dose, you know, one challenge, 20 mLs per kilogram, just get something in them. Too much fluid, you get wet lungs, that's not good. But they're already kind of bleeding internally somewhere, like liver, spleen, or something like that. Like kind of like starting the stuff kind of slowly going in is not going to be a bad option. Again, I call the doctor and ask the doctor. But anyways, in shock, we could have someone who's maybe a septic shock would have dry mucous membranes, skin tenting, some fontanelles on a newborn, obviously tachycardia or low blood pressure, and of course the big one, the peripheral vasoconstriction, which gives you the reduced capillary refill. As I talked earlier too, oliguria's lack of urine. The kid was, you know, using up 3 or 4 diapers a day, now using 1 diaper a day. Haven't changed it in 4 hours, it's still dry. So as a kid, it could be septic shock, dehydrated, things aren't going right. Okay? So much on shock kind of basically. The formula is, we all should know, is that 20 mLs per kilogram over 5 minutes, repeat times 2, then call it medical control. In the paramedic protocols for Maine, after you've given 3 doses of the 20 mLs per kg formula, after you've given that, then you can start moving to things like norepinephrine. But really, more to that point, you should be stopping the bleed. And by the time you get the stuff mixed up in the pump and pump running, pretty much everybody out here will be at the hospital. I do it. don't take my word for it. Okay? You could be in a snowstorm, 4 feet deep of snow, stuck on the road, and all that noise. So seizure is another medical issue that can happen to kids. And seizure events can occur. The common seizure is going to be the febrile seizure. That's a couple of slides later. But you also can have kids who have seizures, born with seizure disorders. It could be from the hypoxic trauma of childbirth, low oxygen levels for a little bit, may have a little bit of scarring on their brain. Different things can happen. There are those who sometimes are born with seizure histories, and I hate to say in the city, there's folks up there who surely know the system well and take a great advantage of it, but there's also people up there I meet in a lot of calls that life really gave them a very bad set of cards, living in poverty because of what nature did to them, and it's sometimes really heartbreaking, some of the stuff. Some of people with bad seizure histories that just can't overcome. And so anyways, you can partial seizures, granulized seizures, things like that, all important. And you look at the seizures, I think it's in here, it's, you want to look at the, the Dr. House theory there, basically, the AEIOU tips. Alcohol use, uremia, infection, epilepsy, and a lot of different reasons there. And kind of like the hunter-gatherer again, I keep repeating that, but it's so important in doing things. And of course, the real thing is, once I start really locking up hard in a tonic-clonic seizure event, if they're still seizing by the time you get there, that's kind of serious. Every febrile seizure I've been to, they weren't seizing when I got there, right? And it's a cold winter day, the kid's got a runny nose, you kind of walk in, I'm not using it because you're sitting there, but basically you can walk in and like, my cold hands, wow, the kids are radiating, like my hands are all warm now, the kids just beaming heat. Of course, I got the kid all wrapped up in an LOB double down bag and all kinds of stuff like that, but like, take some clothes off the kid, let's let the heat get away from the kid, But the real true seizure events, what happens is, in adults as well, is that tonic-clonic muscular activity, or lack of it, basically just kind of shuts down their breathing. And after a couple of minutes of not breathing regularly, they start getting hypoxic and blue and not looking good. There was one lady who was at Seven Tree Manor, or now we call it what, Crawford Commons? Where's Mike? Right there, and she was a seizure once a week. And you got there, she was still seizing and she was blue. And so she had some big issues. Anyways, we look at that. Respiratory failure can occur, so it may be a case where you may have to, in her case, we did get the BVM out, puff her up a little bit, get some air into it. ABCs and spinal mobilization was a trauma situation, all that good stuff. But the febrile seizures are kind of a common thing, and as he ages, and more boys than girls, and most of them last for like 15 seconds. They also may fit into that thing I talked about earlier on Peak 1, the brief, resolved, unexplained event. Okay. And febrile epileptic, metabolic imbalances can do it, so can poisoning and trauma. God forbid trauma, and pretty much those kids can also be the ones who are sadly subject to tensional trauma. Anyways, Pokemon came out back in '97. According to websites, I go research all this stuff, And, a whole bunch of kids went to the hospital in Japan when Pokemon came out because of the flashing on the screen, Like back at some of the pictures I have and all kinds of things right here. Little Erin is now 21 years old, graduating from a Maine College of Art in Portland in May, and she was a pup now. Things have changed, One of my other pictures I have in my seizure pile from years ago. Was Dennis Campbell holding this kid, Marcus, who many of you know took his life about a year ago. Stuff I find I don't think I ever see again. Well, anyways, metabolic seizures can be juvenile onset diabetes. Those kids will be hyperglycemic, probably full volume respirations blow off the acid, crystal clear lungs, high sat, and you hit them with a glucometer and it's going to be high, 800 whatever type of thing. Even kids like that getting brought into the hospital in Augusta, everything is clear, like, won't start insulin, and they won't. They'll put the kid on the ambulance, drive the kid to Maine Med, so Maine Med will start the insulin regimen. The kid is like unresponsive, not doing good, acidotic, right? They won't dare touch that. That's a good sized hospital. Probably the same thing happens at Penn Bay or Miles, I don't know. I think Penn Bay probably just calls Lifeline, calls Angel, But course, we also have diagnosed diabetes and all that stuff right there. And a common seizure call can be febrile. Kind of this is a scenario we mostly see all the time. Kids who are strangers, he's awake, hot to touch, no prior injuries, no prior seizure event, had runny nose for the last 12 hours. There probably could be a febrile seizure. And however, though, that what's happening there is that, yeah, we saw a seizure, yeah, they're hot, they kind of look okay, but there could be something viral going on, that you put the kid to bed the next morning and be really super sick and almost dying on you. So we do, where's that kid belong? At the hospital, you know what I mean? So we'll take him out, you know what I mean? And, you know, yeah, you know, let's go, you know. Rate of rise is sometimes more the culprit, all the stuff you look at. Not the actual temperature, but the fact that it went up so fast, okay? And for us, the methods to cool them is just basically get the shirt off, cool them off by the air. No ice, no alcohol baths, and don't dunk them in the tub, things like that, you know. This little guy launched out of the Walmart shopping cart. Mom gave me permission to take a picture. And he is on a KED, you can really tell if you look kind of closely there. I do like to mobilize a kiddo, especially when they launch out of a shopping cart. And leaped out, and when he hit the floor and all concerned, he had a brief seizure activity. So like to me, this is worth a trip to the ER, you know what I mean? And he was immobilized on the KED and all kind of stuff, because it's kind of important, you know what I mean? And hours later going back there, he was still kind of snoozing, but he was okay, and CT scan, all that stuff was okay, and I went to main med, so I guess he had a happy ending, you know? Folks who are, yeah, where is it? Oh, here we go. Maybe you've seen this before. This is Diastat. And it's a common medication for those with known seizure disorders. There was one little lad, 5 or 6 years old, in the Rockport area at a special school, who was getting Diastat once a week, and a subsequent 911 call type of stuff. And the Diastat is diazepam stat quick, okay? And an anatomically friendly applicator. That's pretty gelled, I think. Years ago, actually, we gave Valium, and I used to give it rectally. I take a 14-gauge plastic catheter off a needle, put the end of the syringe, the barrel, put a little KY on it, and kind of introduce it nicely, gently, and squirt a little bit there, and all that kind of stuff. And so, I mean, that was the thing we could do where they took Valium out of the drug box, but many people will have Diastat. The latest ones of these actually have a dial where they can select a dose. When I got this from a trainer, the guy, the pharmaceutical salesman back then, you could get like, you get 5, 10, or 20 doses. Now they can dial it. Okay? And like there's one little young lady in Augusta who's got this the school folks know how to take care of it. And the instructions are, when she's seizing the school, clear all the kids out, insert it, just dose her, call 911, we get there. And by the time we get there, the mom's getting there as well. And pretty much everything's okay. Just take the kid to the hospital and it's okay, you know. But that's Diastat, and you know, so that's how I kind of look at it. And when I first heard about this stuff, I went to a house, actually a house in Randolph, 126, and the young lady was like 10 years old, but she was silent, kind of quiet, and all that stuff. And this was laying on the floor, just like that. And I looked at that thing there, like, wow. That went up somebody's butt. I did not know that you pull that off and did this, you know. And then one day I was at that call in Rockport where that young man was kind of a common thing, and this was on the floor, and Dennis, Holly's Dennis there. He was going to pick it up, put it in his pocket. I said, "Don't do that. It's contaminated." "What is it?" I said, "Oh, okay." That's Diastat. You've seen it a lot? Yeah, you don't have that, okay. You find it in nursing homes too for elderly people. It's kind of a common thing. So, okay, yeah, all right, okay. So that's my medical stuff I wanted to cover. Kind of on time. The other thing I had was, okay, why don't you take 5 minutes. I gotta switch to my other one here. times had some fun with it. You were there, Walt. We had in Warren, and a young lady had sit out in my car, kind of a surprise. She already was, Lena, was like 5 or 6 months pregnant at the time. And she kind of like had a baby in the parking lot, kind of like, you know what I mean? And it was kind of cool and everything. And next thing you know, pictures all over the Facebook are like, oh my God, you had your baby in the front seat of a car, you know? That's nothing, no, it was, it was a class, you know? People looked at, she had a little guy, a couple months later, little Theo, he's a cute little kitty, pictures I see of him. So anyways, newborn care. And all the childbirth calls I've known about, it's always been a situation where the child was born before EMS got there. On the side of the road, in the parking lot, in the home. So kind of like, you know, like all the other stuff about do this, do that, don't push mom, have a balloon, whatever, 3 months, what, you know, like at that point, yeah, whatever. Okay. What matters to us is going to be, you know, like somebody pulls over in the parking lot out here, where the hospital, all of a sudden, out comes Johnny. That really is our job. I mean, that's happening so much. So that's kind of where I started pointing the stuff in that direction. Only based on just what's happening out there. So I put together newborn care. Yep, baby born in the car on the way to the hospital. Yep. 20 in Maryland. I guess it's probably Maryland, right? Baltimore County. I've been there before. So anyways, a few things to talk about in childbirth and all that stuff right there. And you know, you can get all wound up on childbirth process and all kind of stuff, but really the neonatal resuscitation flow chart is kind of more important to us. If the baby's doing well when we get there and everything's looking fine, then holy cow, this is great, you know, and you know, rock on. And the time baby was born was, you know, all that stuff. But things aren't going good with the kiddo, and we get some work to do. And I got the clicker, so there we go. Will that work? Okay, all right, so, okay, well, this way here, okay. So pre-delivery considerations, if you had the luxury of getting there before mom's delivered the child, getting ready for childbirth and making a decision to stay and play versus load and go, there are things to be asking about, how many pregnancies before, a lot of stuff, how many weeks pregnant, prenatal care. And yeah, recreational drug use is a big issue out there, and it's in here later, but somebody I know used to work on the Angel truck, and talked about you know, the signs of kids with neonate abstinence syndrome, which is the baby's born to an addicted mother, the stuff's in their bloodstream, they're born, they need a fix as well. And what they sound like, all kind of stuff. She says, why? When you work in Northeast on the Angel truck, basically your job is get in the front seat and drive. Don't get involved with what's going on in the back. So she could hear those cries and like explain that to him, like, wow, I heard that so many times, you know what I mean? And that's sad, you know. Anyways, if you got the luxury of getting in before the baby arrived, have the membranes ruptured, any other medical problems, will you check for diabetes, gestational diabetes, things like that, any seizures, you know, all kind of good stuff. That's all stuff to ask. And preeclampsia, eclampsia conditions can occur. 100 women will have it and can affect the placenta. Pretty much getting good prenatal care. People get screened for this and get taken care of. And we look at one of the important ones too, the main EMS protocol. Postpartum up to 2 weeks after the childbirth. Mom's having seizures up to 2 weeks after the birth. That falls under postpartum seizures, and that's going to be dumping the magnesium. And when we lost the vials, something like that, they loaded in like a whole ton more. Yeah, it was a whole batch, but then it came out and go back to regular. So, and anyways, 4 grams IVO over 10 minutes, and if not, the 8 grams. That's a lot of stuff to stick into someone's buttocks, I tell you, you know that. But, oh well, yeah. It's a lot of medicine, you know. And diabetic history is kind of important. Mom who is taking insulin, it does affect the newborn's ability to maintain normal blood glucose as well. They're going to be born with this as well. And the kid will have the hyperinsulinemia type of situation going on. And when the cord gets cut, newborn no longer gets the glucose from mom. And I do know a young lady, I'm not sure if anybody here has met her. probably not. She was a pump, a great young lady, and she just had a little guy, and he was about 6 weeks premature, tiny little critter. And he was a Maid Med for about a month, and he moved to Lewiston to be closer to home. And she said I was going from Hampton Inn to Motel 6 in Lewiston with the NICU. But he was fine, everything was good, and I see his pictures on Facebook, and he's a cute little kitty and all that stuff right there. And she wears a pump, and the baby's fine, so it's good, happy ending. For adult seizures, I think I did cover that already. I'm on the wrong direction, here we go. So this is a growing problem. When I first heard that phrase on the main EMS drop-down menu type of thing, I'm like, neonate abstinence? Obviously somebody didn't practice abstinence long ago, but I mean, like, what does this mean? I had no clue. And it was folks who are pregnant and shooting up and all that stuff right there. And we're not seeing any of that up in the city. Probably, I don't know if you're seeing it, I don't think it's happening out here at all, but places like Lewiston, Lewiston's having some bad messes, and there's a lot of, some of us out there, you know. And there's a good website called Rescuing Providence. And it's a retired rescue officer on Providence Fire Department. He writes a whole bunch of paperbacks on that, and he talks pretty heavily about all the narcotic overdoses, pregnancies, and all that kind of stuff in the field in Providence. And he writes about a lot of stuff. It's kind of like surprised he can write about it, but he did. So, yeah. Anyways, we don't give Narcan in the field. It's going to be a screaming, crying baby, very irritable. Nothing's going to make sense, and probably that's why. So anyways, those child's going to have withdrawals, instinctive cry, high-pitched, non-stop, and increased motor reflex. Kind of surprised me when I saw that, but tremors, irritability. The motor reflexes when the kid kind of does that little thing with their arms like this right here, like kind of like the ballerina pose type thing. So withdrawing, they're going to have all that happening, and hopefully that's not the case. But when you find out that they've had no prenatal care, I don't mean to be social economic labeling people, but some people you can just look at and say, like, this person has not had a good lifestyle, and there's a lot going on probably in their life and all kind of stuff, and like, you know, kind of like when the police hunt around, kind of like, have you been using? If the police are right there, you ask, you may not get a straight answer. In Augusta, every time we have a narcotics call, we get like 5 cops showing up. If they squirt Narcan, they get a little pin to put on, they save the life. Yeah. So, it's like you have to get all the cops out of the way now in Augusta to go to a call. You know? Well, whatever, you know. So anyways, baby is born, you arrive, get there. There's a transition to extrauterine or outside the womb. So we want to suction the mouth first. And you know, the bulb syringe is a very important tool to have in your truck. And a PD kit, handy at all times, for newborns as well as 6-month-olds. Keep baby level with the mom. Not too high, blood drains out of the kid. Not too low, too much blood goes in the kid. Keep the kid level. And I'm not sure about Media's protocol, it's kind of silent, but now we're looking at 30 to 45 seconds later to clamp the cord. Okay, let some blood flow utilize, and there's good reasons for that. And dry, stimulate, warm the baby. And the most important thing is to keep the baby warm. The front seat of a car, kind of tough to do, but crank up the heat and all that, get lots of blankets. And keep the kiddo warm. And neonate resuscitation, so the top block there basically is its full term. Is it breathing, crying, and kind of like moving around a little bit there? Then yeah, let the baby stay with mom, skin to skin contact, get them warm, congratulate them. Routine care, dry, stimulate, clear the airway if necessary, and basically find a way to give them a safe ride to the hospital. Having the baby on mommy's chest going down the road is not a safe situation. That's a tough dilemma for us because you got to take the kid out of mommy's arms, put in a car seat. I know you got the PD sheets here, the vinyl sheet there with the seat belts, which are great. A lot of places don't have those, so there's a lot of problems with that right there. But anyways, if the kid is not crying, not breathing very well, not good muscle tone, we want to warm, clear the airway if necessary, dry, and stimulate. And that's why I say you need 2 PD kits. I don't need 4 clamps. I don't need 2 bulb syringes, but everything else I need double of. I don't need 2 placenta bags, but whatever, okay? You need lots of towels, you know. It should be clean towels, all kind of stuff right there. So, we want to dry, stimulate, like 30 seconds worth, and kind of reevaluate the kiddo. You should be doing the APGAR score, but whoever's on that, I don't think anybody has yet, because if they're breathing and pain, all kind of stuff, good enough for me. So anyways, if the heart rate is below 100, gasping or apnea, then we start using positive pressure ventilation, the BVM. If the kid has some tough respirations, all kind of stuff, with a manometer equipped BVM, your first 2 puffs can be up to 40. Just your first 2. Then bring it down to no more than 20. On your pediatric neonate type BVMs, if the kid has got a meconium stain or a big pot, oh, horn's gonna call. Main Street Apartment 2, okay, sorry. And the BVM, I can dial up to, if I have to, I can go up to, there's 40 right up there, okay? I want to stay in the green zone for neonates. That's what I want to do also. And on your infant BVMs, it's also part of the neonate resuscitation class, is that the kiddo, the little newborn has got fluid you can't clear, you're getting hypoxia, things aren't going right, and you want to try to blow some of that snot back into them, then you're allowed to take and close off the bypass valve for the first 2 breaths, no more than that. Any more than that, you can cause chest trauma, barotrauma, collapsed lungs, pneumothorax. And actually, those things are very common when you talk to NICU nurses. Okay, so normally when you have an obstruction on the BVM, on the infant one, you hit a whistle popping, a little whistle pop. When I throw the lock on, now I don't have that. So the first 2 breaths can be locked and up to 40. And then lock off, and then go back to normal ventilation, so the kiddo. I got lungs here, stuff like that, but I'll pass it around. Let's look at it. And then, like, to get the manometer on those is like an extra $10. You can use it once every 10 years. But if you need to use it, and things aren't going well, it's probably the tool to have, it's worth investing in. So, anyways, heart rate below 100, and we start using positive pressure ventilation, and monitoring, we do monitoring, that's what we call it more later as well. We want to attach the pulse oximeter to the right wrist, right hand. And that's called preductal saturation. I know it was a long time ago. Remember I talked about the vasculature of the heart before the child was born, had that open ductus arteriosus? If that doesn't, that's after the aortic arch. So when I take saturation on the right hand, I'm getting preductal saturation. Whereas after that point, it could be blood that's mixing and not really accurate. If you look in your protocol too, you'll see the phrase preductal saturation. That's what that means. Oximeter on the right wrist. So anyways, heart rate below 100, ventilation, correction steps, all that kind of stuff. And, if you like, a couple minutes and you're ventilating the kiddo and rate's not picking up, hopefully it gets better. If the heart rate gets below 60, then we're going to do chest compressions. Okay? A healthcare provider is what ratio? 15 to 2. And healthcare provider should be 2 hands, thumb encircling technique on the kiddo. Okay? 1, 2, 3, 4, 5, 14, 15, 16, puff, puff. Okay, type of thing. Okay? And that doesn't correct things after a certain amount of time. Then at that point there, IV epinephrine is also on the list. When I take neonatal resuscitation, I've been in Bangor, and the lady up there, Ann Boomer, she's a nurse practitioner. She is the whiz of Bangor's NICU, and she uses epinephrine like so. It's like almost like she can remember last time she was so rare. But plenty of kids get ventilated, intubated, all kinds of stuff for quite a while until they overcome things that weren't working right in the beginning. So it's and if you see on the chart over here, it says targeted preductal saturation after birth, 1 minute, 60 to 65%, 2 minutes, 70%. Okay, so after 1 minute, we're looking for a 60 to 65% preductal saturation. It's really kind of low, but there's still kind of mixing going on because that ductus arteriosus really hasn't closed up yet. And when to ventilate? heart rate below 100, respiratory rate below 30, gasping, chest retractions, and we can't make cyanosis go away type of stuff. And what they're using there is known as a neopuff. A neopuff is also known as a T-piece resuscitator, and they now have them disposable, like $80. I'd love to have it on an ambulance if I was working on it, because it's like such a cool device. And a T-piece has a peak inspiratory pressure setting, so you can set to like 20, okay? It also has a PEEP, like you set to like 5, and the oxygen air mix is flowing up to the tubing to the mask, and all you can do to ventilate the kid is put your finger on top, boop, 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 just like that. Heck of a lot easier doing that for an hour than squeezing the bag for an hour. My hand's tired, try the hand. You got, my hand's tired, you try it, you know what I mean? And the T-piece resuscitator is a cool device, and almost like, it's never had a problem in Maine, but it'd be almost going to be great to have in an ambulance. It'd be a cool toy to have. Anyways, saturation monitoring. We have a preemie. It's also a picture of a preemie who is wet and cold, and everything, not retaining heat. One of the things that happens with preemies is they get cold, so one of the recommendations is to actually stick them in a Ziploc bag. It helps retain the heat. Pretty simple, you know. And Saran wrap does that. That's what's kids in Saran wrap. And if you look at pre-ductal saturation, okay, we're going on the right-hand side where the oximeter is. Oximeter is this little guy on the right-hand side. And this is a mannequin, okay? And here, right here we go, right wrist. Okay, newborn. That's okay, you know. So here's a newborn. He's been dried off a little bit, cleaned up a little bit, but look where the oximeter is. And look what his oximeter reading is on the screen.
100%.
He was a month premature. So pre-ductal saturation for him, that's incredible, okay, strong. And that's the chart right there, a little bigger version. And that's the reason why we're trying to have pre-ductal saturation. Okay? And one of the things they do in the critical care stuff basically is that they have pre-ductal circulation, right side, and post-ductal circulation, left foot. If there's a greater difference of like 10%, then that's a kid that needs Angel Team, Life Flight, all that kind of stuff to get to main med, because there's problems with the vasculature of the heart not closing up and everything. Or maybe there's holes in the heart that aren't closing and all that, so. All the reasons why I'm not sure, but just that then it's kind of a problem. Oh, here we go, yeah, I do have that, okay. My picture's a little better, but you can see here, look at the hands. Blue hands, blue feet. Well, the feet you can't see on the picture there, I got them in the picture, but blue hands. But that's normal for like an hour or two after birth. That's fine. Okay. But you can have congenital defects that can be coarctation of the aorta is when the aorta makes the arch and it narrows, it tightens up, restricts blood flow. That's a surgical repair of a kid. You can also have septal wall defect, the heart valves, the holes, the walls aren't fully closed up. I think it's called foramen ovale. Okay. So those are all kind of critical things that can happen. And for us, really, at this point, you could have a kiddo in the field who's not looking good, newborn. Whatever the reasons why, I don't know. It could be, the list is long. But you know what, though? What are we going to do? Keep them warm with the ambulance, put them on initially, transport the kids safely, ventilate the kid. If you doubt you need to do it, go ahead and ventilate them. Ventilate them gently. Time it with them, use a BVM, hopefully a manometer type of stuff. Don't cause burial trauma, don't go trying to jam air into them, just kind of give them little puffs, little tiny puffs. If you're gonna put a simple oxygen mask on a baby this size here, the best thing you can do is actually take the size of the mask, fold the mask in half a little bit, crimp it, cut a corner in the side of the mask, so when you let it go, the mask has got a hole in the side. You know your nebulizer mask has a hole in the side? Make a hole in the side of your infant child mask. All the oxygen flowing in, they're going to breathe in. All the CO2 they're going to blow out is going to go out. You put a mask on a baby who's got very little ability to effort and volume movement, not enough energy to move stuff out, they can retain CO2 and have hypercarbonic respiratory failure. Okay, now from probably that end of Wallabro to Miles, it probably wouldn't happen. Port Clyde to Penn Bay, it could get hypercarbonic, it could get too much CO2 built up, it can't blow off. So cutting a hole in the side of the mask prevents that. Okay, just a little tip, you know. And of course, less than that, less than age, they got insufficient brown fat, and that's what does metabolize and produce internal body heat in the newborn. And these kids will get cold very quickly and not do well. So cutting, clamping cord is now delayed for like 30 seconds at least. It's reasonable according to the American Heart Association International Liaison Committee on Resuscitation statement. Is that keep the neonate level with the mom. Right now the neonate is not. She's a mom. The baby's in mom's chest, but at first initially 30 seconds or so. And I know Humanitas protocol doesn't say anything about that. I'll talk to Pei about that one of these days. And he's my direct line to the MDPB. Well, most of the stuff I send him he dismisses, but whatever. Well, he knows I'm alive. And there's a resuscitation tree again. And okay, so with that, what's our first steps to taking care of a baby? Probably warm, okay, dry, stimulate. Okay, cool. Okay, so we want to have a whole bunch of like towels are good to have, and all kind of good stuff, very important, you know. So he went out to the street out there, and lo and behold, somebody just had a baby, and here's a kid in the front seat, and who wants to go to work? Has a baby, take care of it. Right?
Alright.
Get a team, get some people together, get some helpers.
Any people just wanna come help warm this little bugger up? I'll come up here.
Ah,
We gotta
a little
dry him up.
participation. Dry them up, stimulate. Okay.
Good Lord, so just so you guys can see, we have actual born baby here with,
Oh, we got BVM. All right, we got.
alright, you want us all
Yes,
alone
the
here.
scope, okay. Oh, look at this, who's gonna put the oximeter on?
Yeah, where's our, bulb
Be on the other
syringe?
side of the table.
Okay, so we're drying and stimulating, okay? And is the kiddo breathing? Okay, but what side do we put the oximeter on? Right wrist, okay, if we can,
Yeah,
okay?
that's it.
Right wrist, okay? Now, we're in it right now, do we have a cry?
Sure,
Okay?
but I still wanna get this gook out of his mouth.
Oh, my baby, oh my God, I got a baby, oh my God. Holy cow. That's happy, you get a tax deduction, whatever. Okay. Okay, here's a placenta hanging out, okay, here we go, okay? So it's been about 30 seconds, what can we do now?
So he's been level with his mom.
Okay, good,
Clamp his
okay.
cord.
Go with his
Okay, you don't use a clamp, just put a clamp there, okay?
Mhm.
Clamp it, okay.
Mhm.
Okay, how's the breathing going? Okay, cool.
Are we
That
breathing?
point there, the baby's pink, breathing, adequate cry.
We have a little
You
head.
don't hear anything going on? Yeah, well, that's a good thing to have. Yeah, that'd be perfect to have.
Baby's
Yeah, okay, and what do you want to do with the baby now? Put the baby
On
on
the
mom's
chest.
chest,
Mom's
skin to skin
chest,
contact?
Yeah.
Still have
Yep,
gook in
and
its mouth.
congratulations, Mom, and
Oh, yeah, do we have
pictures
a-
and tears and
touch and
happiness and
thing?
all that good stuff. I've been there, I've been there. I've got 4 kids.
So let's warm this little bug up.
Nice. Well, isn't this lovely?
Since it's actually on mom, but he's still on the.
Cool, okay.
Couldn't get all the gunk off.
Okay.
Congratulations, Mike, Sue.
Okay, let's do,
Out of the mouth to feed.
oh, no. That's so Republican of you. All right. Well, people say that, you know.
Take him in and clean him off, Kevin.
Well, it's, you know, I think one of the, I think a little more, you don't have enough people participate with that one, you know that? You know, we don't have enough people, let's get this kid messed up, let's have another newborn back here. Oh, she's having twins, oh my God. We got twins here. Holy smokes, look at this. Twins.
In the dark, in the kitchen.
I need some folks to help out here, hey, come on, you know, I mean, like, wow, here we go, and. Okay,
Look, girl, start the IV.
Hey, here we go, we got twins. And this one, my God, what's going on with this one here? Hey, help.
Director,
Oh, meconium.
I need
Get some helpers.
Calling a
I need some
helper.
suction
Well, come on, don't sit here, come on, do something, help him out. Right? Little guy sick on his own, come on. Meconium staining, years ago, was a big elaborate method of suctioning the kid's airway with a meconium aspirator device and a 2.5 ET tube and all kind of stuff right there. Nowadays, just suction out with the bulb syringe
You have
and
one?
just start to ventilate him.
He
you know.
needs one.
What's that?
He needs one.
He does, okay, well,
You
yeah,
have
he's-
one?
yeah, he does, yeah.
I'll clean you.
Actually, I see him run pea soup on me, so, you know.
Oh, peace.
Pea soup, yeah, pea soup, okay, that's my, you know. You've seen my drill before, haven't you? I did it to you one time with the class. Okay. And so meconium staining, basically suction the airway with the bulb syringe, or use your regular little suction type device as well. Clean out a little bit, but don't spend a lot of time. Don't spend so much time pulling oxygen out and air out, trying to pull out yuck when you have the expense of getting oxygenated. Because a kid who's had a meconium stain may be stressed, not vigorous, limp, and not doing well. That's a kid who probably may need EVM ventilations, warmth, turn up the heat, right? Bring the heat in this truck, okay? Wrap him up and pretty much like, hey mom, hang on mom, give him a kiss, but we're gonna keep him warm, mom, and we'll take good care of him. He's okay, but just we gotta take care of him because he's a little extra attention, but he's fine. He's 10 toes and 10 fingers, everything's good, you know, all that type of stuff. Reassure mom, and you'll be doing some, you know, baby care, that kind of thing. So, okay, so that's kind of my class. So
Life saved.
Life saved.
Oh, you went out with a bang.
Oh well, you know.
Thanks, guys.
Thank you.
Thank you guys.